I am Vishnu. I'm very excited to start the PBC Practical Knowledge Perspective series. Actually, the past 31 videos that are there in my YouTube channel under specific playlists, they are also related to practical knowledge. But now what I did is, since I am preparing for PBC and there are a lot of people who are literally confused as to, they find the exam very tough. It is actually one of the toughest exams in the world. You don't get direct reference materials as to how to prepare. Lot of confusions are there, and you have only limited number of attempts to actually write the exam and clear it. So I will never tell you that the materials that I'm giving you here or the lectures that I provide you here will be the ultimate source of reference. Definitely, we have standard books. You can refer them. Even if you go to the Canadian website also, the pharmacist website, you will find they have written a lot of references of different books of different subjects. But I can definitely tell you that I can give you a good foundation, a foundation which can help you develop on in the later stages. My name is Vishnu. I finished my PharmD. I'm a registered pharmacist. I have a diploma in nutrition. Definitely, as you know, that I have a YouTube channel where I give my lectures. I had been an assistant professor in the Department of Pharmacy Practice, where I dealt with 5 subjects, 2 therapeutics I had a clinical toxicology, clinical research, and pathophysiology. Actually, I purposely selected those subjects because those were actually good for my practical knowledge perspective also. Even if anybody who is listening to this is a teacher or a professor, I always personally advise you that if you are having future goals as to work in a hospital as a CP or anything like that, please make sure that you select subjects which are good for your, practical knowledge goals. And now I'm working as an executive clinical pharmacist in antimicrobial stewardship department. So welcome to my lectures. Today, I'm going to be talking to you about route of drug administration. So this is actually a general slide which you will find in all presentations of mine henceforth. What are the things that you should expect and what are the things that you should not expect from my lectures? Actually, this is a kind of special disclaimer which I think that I should be sharing with you so that if anybody is watching this for the first time or if anybody already know, but still you should know about this, so that you don't have expectation clashes or something like that. So what are the things that you should expect? Practical knowledge of the highest level. I always tell people that it is very easy to work hard, but it is not easy to work smart. Working hard means you are having all the scholastic accomplishments. You are getting a distinction, you're being the topper in the class, you're getting, maybe you are the university topper or something like that. But after the exams are over, you don't remember anything. So that means you lack practical visualization. So this presentation and henceforth all presentations will give you an insight into that. A foundation for applying yourself to faring competitive exams, including PBC better, including because I am personally preparing for that. There are so many people, as I said, who are confused and many people exactly don't know what to do or go ahead with. So I hope that my lectures from now on will give you a good foundation for preparing PBC, and not just PBC, any competitive exam. So please don't think that this presentation is just for people who are studying or preparing for PBC. Even if you want practical knowledge of the highest quality, definitely my presentations might be a good source. Obviously, it depends on you how you perceive it. A guide in how to make good notes and presentations. This is something that I learned from my experience. I have around 400 plus notes. And I still remember the initial notes that I made were absolutely bullshit. The reason is that whenever I used to read a book, I used to simply copy down those things. Then I realized what is the point in doing that? Then the easy thing is to read the book itself. Most of the books that we read for pharmacology, therapeutics, or whatever subject it is, are actually boring. Although they are rich in knowledge, they are actually boring because the way it is presented is very boring. So through my notes, which are available in LinkedIn, you can contact me there. Through my presentations, if you contact me in LinkedIn, I'll share with you. You can get an insight into what I actually perceive while making good notes. Anyways, I'll come with a video on how to make good notes and presentations. Priceless knowledge free of cost. Always remember, there are many people who ask me this question, whether my notes or my PowerPoints or any lectures of mine are payable. Please remember, it is not. There are a lot of people who are already doing business with their coaching, guidance and things. I don't criticize them. But if I also start becoming like them, then how can Vishnu be different? So you can consider all my lectures free of cost. Knowledge from standard books and references are a refined version of study smart concept, because I'll be referring the updated guidelines. I'll be referring standard references, websites, apps, lot of things. Whatever I get as a summary, that I will make into handwritten notes. I'll convert them into PowerPoints and I'll be explaining that to you. So definitely it will be a study smart concept. Please don't expect theoretical knowledge from my presentations. Please expect practical knowledge from my presentations. Handwritten notes or PowerPoints for every lecture. So from now on, and even in the past also I had made many. If you want, you can contact me in LinkedIn. I will definitely be very happy to share them with you. So it will give you an insight into how I make notes, how I make slides and everything. You will get an idea. What not to expect. Direct material for any competitive exam. Please remember, this presentation and any presentation in future, they are not intended to give you direct material for any competitive exam, including PBC. This is just to give you a foundation on which you can apply yourself and think which is the right method for you to go after. This presentation or my lectures will never give you a guarantee that only studying this will secure your exam clearing chances. Please remember this. I am not giving you any assurance that this lecture or future lectures will help you clear your exam. That depends on how you prepare, how you understand my concepts, and how you complement it with other references of your personal choice. So if you study smart, then definitely not just PBC, any exam in this world will be easy for you. Any sort of payment for any lecture. Please, there are a lot of people, as I said, who ask me this question, whether my lectures, my notes or PowerPoints are payable. Please remember, it is not. There are so many corporate organizations, there are so many people who are already doing business with their lectures or guidance or whatever it is. I don't criticize them. But my personal perspective is, your parents are already spending a lot of money on you for your course. You are not studying on a scholarship. In that condition, I don't have any authority, and I personally don't find it ethical to take any money from you. So you can consider my lectures and my notes or PowerPoints free of cost. So let's come to the presentation. So first we'll go to the factors which affect route of administration. There are two factors. First is called the properties of the medication, and the second factor is the therapeutic objectives. So properties of the medication, like for example, if how soluble it is, whether it is water soluble, whether it is lipid soluble, and whether it is having any kind of ionization property. Then we come to therapeutic objectives, which is much more important. Do you want a rapid onset of action? If you want a rapid onset of action, then intravenous is one of the best methods that you can consider. Is long-term treatment required? So it depends on what kind of, for example, there are certain medications. For example, haloperidol, risperidone, which are available as depot injections. intramuscular depot injections, a single injection, and it will work for a lot of days. So it depends on how long you want the treatment or what kind of treatment do you want, whether you want a long-acting depot injection or whatever it is. Restriction of delivery to the local site. So that is also important. So for example, if you are applying any kind of topical formulation or topical application, you will definitely apply at the area where it is affected. You don't want it to go to other areas, or you don't want that formulation to go to other areas. And this is actually applicable for all the formulations which act inside the body as well. So this is just a very preliminary concept, the factors which affect the route of administration. Now we come to the different routes of administration that we'll be talking here. One is called the enteral administration. The other is called parenteral administration. The third is called rectal administration. And the fourth is called other routes. So in other routes, we'll talk about transdermal patches. We'll talk about, intranasal oral inhalation preparations. So like that, some are coming. So we'll talk about that there. First, we'll talk about the enteral route of administration. So this refers to any medication which is administered by mouth. It is common, convenient, and cheap. You know very well that most of the oral formulations, it is very commonly used because it is easy to administer, it is convenient, and it is cost effective. Not all medications, but most of them are cheap. So they are classified as oral route, or they are classified as sublingual or buccal route. Let's talk about the oral route. So the rate of absorption depends on the type of formulation. We have two types of formulations. One is called enteric coated preparations, and the other is called extended release preparations. So if we look at the enteric coated preparations, so it works in the following steps. Number one, enteric coated preparation, like for example, you are taking a enteric coated omeprazole tablet. So omeprazole is a proton pump inhibitor. So how does it act? This tablet protects the drug from stomach acid. So when it is an enteric coated, it will protect the drug from the hydrochloric acid and all the corrosive substances which are found in the stomach. This drug then directly goes to the intestine, and the intestine is less acidic. The outer coating dissolves and the drug is released. So in enteric coated, what happens? You take the tablet bypasses stomach acid, it goes to the intestine, the outer coating gets dissolved, and the drug is released. This is actually applicable for those kind of drugs like omeprazole. For example, omeprazole, if you are taking normally, it is actually highly susceptible to acid destruction. So for example, if you are taking normal tablet of omeprazole, what happens is that it will get destroyed by stomach acids. So you won't get its pharmacological action. So enteric coated omeprazole is a good idea. Then we have enteric coated aspirin tablets. Aspirin, when you take inside, it is highly irritating to the stomach. You know very well that aspirin usually causes GI disturbance as a side effect. So if you are taking enteric coated aspirin, goes to the intestine, the outer coating dissolves, and the drug is released. Then we have extended release preparations. So extended release, how it does is, it also has a sequential flowchart or a proper sequential steps. The drug contains a special coating. The special coating delays absorption. That means absorption does not happen rapidly. That is why the name is extended. So slow absorption means it increases the duration of action. Always remember, fast-acting medications, if the onset of action is rapid, the duration of action usually becomes less. But if the onset of action is slow, the duration of action becomes longer. So extended release preparation means their objective is to delay the absorption so that the molecule works for longer periods. So the benefit is, since the duration of action is very huge, it actually improves patient compliance. Like for example, you have to take a tablet, normal tablet, you have to take 4 times a day. But if you are giving it as an extended release preparation, maybe you have to take it only twice a day. So there is a chance that the patient will not forget, because 4 times a day the patient may forget. But if it is 2 times a day, the remembrance will improve. Immediate release formulations have a problem. They have larger peaks and trough levels. So that is why it is actually a demerit, because immediate release means the drug is suddenly released or very soon released into the circulation. So the peak plasma concentration and trough levels will be very high, which is actually not a very good idea, because the risk of toxicity will be huge, and at the same time the duration of action will be less. But extended release formulation provides sustained concentrations within therapeutic range. Within therapeutic range is very important, because whatever medication you are taking, always the goal of therapy is to maintain a therapeutic window. Therapeutic window means there should be a balance between efficacy and safety. So this will give a sustained formulation or sustained release of the molecule within therapeutic range over a longer duration. Extended release formulation are actually used for those kind of drugs which are having extremely short half-life. So when you are using extended release formulation, the half-life increases. So we have given an example here. Morphine, the half-life is only 2 to 4 hours. So if you are giving it as a as a medication for chronic pain or something, so you have to give it 6 times a day, because 2 to 4 hours means you can understand very well. It has to be given 6 times a day for continuous pain relief. So that is not a very good or applicable idea, because the patient has to get up in the middle of the night also to take this medication. So if we use extended release morphine, just 2 doses are enough. So that is the benefit of using extended release formulations. Now we come to the merits and demerits of oral route. Merits is, it is a safe route of administration. It is very, very convenient to be used. So it improves the medication adherence. And it is also a cheap route of administration. So all those things I've already mentioned before. If you look at the demerits, there are certain kinds of food which may negatively impact the absorption of oral medications. For example, levothyroxine. For example, warfarin. Warfarin, you know very well, it has a lot of drug-food interactions. So like that, there are a lot of medications. For example, you can consider doxycycline or tetracycline also to some extent. So food might negatively impact the absorption of medications. Patient compliance is worrisome if the drug has to be taken multiple times a day. So this usually is a matter of worry for those kind of medication whose half-lives are very less. And if the extended release formulation of those medications are not available, then definitely it is a matter of worry. So for example, you can consider levodopa. So levodopa, in some conditions, what happens is you have to take it almost 4 times a day. So in that condition, there are chances that the patient may forget or skip a particular dose because of lack of remembrance. The drug is metabolized before reaching the systemic circulation if it is an oral route. So lesser drug will be available for activity. This is very simple. The plasma drug concentration might get reduced. That is why when you are giving through the intravenous route, the plasma drug concentration is usually very high, or the bioavailability is usually very high. You cannot give any medication through the oral route for unconscious or comatose patients. Obviously, that is quite understood. There always is a risk of choke and all this kind of issues. Oral formulations are not applicable to all medications because there are a lot of medications which you cannot give through oral formulations. So either due to stability issues. So that is why that is also another problem, that you can't give all medications orally. Now we come to the buccal or the sublingual route. In sublingual route, the drug is actually placed under the tongue. In buccal route, the drug is placed between the cheek and the gum. That is the difference. You cannot consider the absorption to be static. Most of the drugs, when you take through the buccal or sublingual route, the absorption is not that much predictable. It can be erroneous in the sense it can be low or high. But there is a medication known as nitroglycerin, which usually we take it as a sublingual formulation. So that actually provides a direct systemic absorption. Nitroglycerin is usually used for the treatment of angina pectoris. Coming to the merits of buccal or sublingual route, it escapes first pass metabolism. That's the biggest advantage. First pass metabolism, if it escapes, that means the bioavailability will be good. It also escapes the stomach acids. There are so many medications which are destroyed by stomach acids. So in that condition also, if you're using through buccal or sublingual route, it will bypass that also. The pH of saliva is usually neutral. So that is the biggest advantage. Like for example, you're taking a molecule which is whose pH is either high or low. And if the pH of saliva is not neutral, then there are chances of incomplete stability or stability issues of that molecule. But since the pH of the saliva is neutral, the stability of the molecule is maintained. And definitely to some extent you get immediate drug effects also depending on the rate of absorption. Coming to the demerits, if you are swallowing the drug, then part of the drug may be lost. And it is also limited to those drugs which can be taken in small doses. You can't take 1 gram or higher formulations or higher dose through buccal or sublingual route. It doesn't make much of a sense. So we have some examples. For example, nitroglycerin and buprenorphine. Buprenorphine is a opioid. Now we come to the parenteral route. So through this route, the drug directly enters into systemic circulation, as you know very well. So this is good for conditions or medications like heparin. Heparin is poorly absorbed from GIT. That's why we do not give it orally. Insulin is unstable in the GIT. That's why we give it as a subcutaneous formulation. But insulin we give IV also. That is a special condition known as diabetic ketoacidosis. And definitely if the patient is unconscious or in a comatose condition, definitely you can't consider oral formulation. Their parenteral is excellent. And obviously, if you want rapid onset of action, if it is an emergency condition, you want rapid onset of action, then definitely parenteral route is a good idea. We have 4 types. One is intravenous, one is intramuscular, one is subcutaneous, and the other is intradermal. Intravenous is the most common route. It usually gives a rapid effect. When if you are giving intravenous route as IV bolus, then the full amount of drug is released immediately. If it is given as IV bolus, the full amount of drug is released immediately. And if it is given as an infusion, the drug is infused over a long period. So that leads to reduced peak plasma concentration and increased duration of action. So IV you can give through 2 ways. One is the bolus route and the other is the infusion route. So here I want to just talk about vancomycin. You know very well vancomycin is an antibiotic. So it is a glycopeptide antibiotic. We have other drugs in that class like teicoplanin, etc. Vancomycin, if you are giving as a rapid injection or maybe IV bolus, that is not a very good option because it can cause red man syndrome as a side effect. So that's why we usually give it as a prolonged infusion. If you look at the merits of intravenous route, you will always get immediate effects. This is also ideal if the drug is dosed in large volume. For example, piperacillin tazobactam, we give 4.5 gram. Imagine 4.5 gram. That if you take it as an oral formulation, it will be difficult to swallow. So if you are giving it parenteral, it's not a problem. This is also suitable for irritating substances and complex mixtures. This is the best route for emergency situations. In emergency conditions, usually we prefer IV route. Dose titration is also possible, that you know very well how to titrate the dose. I'll come to that in future videos. And it is also good for high molecular weight proteins and peptide molecules. If you look at the demerits, it is not suitable for oily substances. Bolus dosing increases the risk of side effects, because side effect is because when you are giving as bolus means a large amount of drug is released into the systemic circulation within a short span of time. So that can increase the risk of toxicity. And that is exactly the reason why most medications require slow injections. As I said about vancomycin, there are a lot of other medications also. Strict aseptic techniques are required, because when you are giving through IV route, there is always a risk of getting infections and all these things. So sterilization of the syringe, lot of aseptic protocols we need to follow. Otherwise, we can get hospital-acquired infections as well. Now we come to the intramuscular route. So this usually exists in two different types of formulations. One is the aqueous formulation and the other is the depot formulation. Aqueous formulation is usually absorbed rapidly. Depot formulation is absorbed slowly. So for example, haloperidol, we have risperidone, paliperidone. Most of them are available as intramuscular injections. Medroxyprogesterone, which is available as a depot formulation. So depot formulation work through the following steps. So these are the sequential steps. First, the drug enters into the body through the intramuscular route. This drug is actually suspended into a non-aqueous vehicle. Non-aqueous vehicle. Vehicle is the medium on which the drug is suspended. So the non-aqueous vehicle, the example can be PEG, that is polyethylene glycol. The vehicle will diffuse out of the muscle. So the drug will precipitate at the injection site. So wherever you gave it intramuscularly, that area the drug will precipitate, and slowly it will get released into the circulation. After precipitation, it gets dissolved, and then slowly the drug will get released. So it provides a longer duration of action. Coming to the merits, it is suitable for moderate drug volumes, not very high. It is suitable for oily vehicles and irritating substances. As I said, in intravenous, we cannot use for oily vehicles, but here we can. And if the patient has to self-administer, intramuscular is preferable over intravenous. Obviously, if you want any kind of injection, you cannot, give it intravenously, because then you need a setup like that at your home. So that, increases inconvenience. So intramuscular is very good if the patient has to administer it by himself or herself. Coming to the demerits, it might affect certain lab values. For example, creatine kinase. So this is actually related to the muscle. When you are giving a medication through the intramuscular route, in some cases, the level of creatine kinase might get disturbed. It is very painful in nature, that you know very well. Intramuscular is painful. There is also a risk of intramuscular hemorrhage if it is used along with or before anticoagulation therapy. Anticoagulation, anyways, anticoagulants, the side effect is hemorrhage because they block coagulation, so it will cause bleeding. And if that time an intramuscular medication is given, and especially if it has a side effect of hemorrhage as well, then we don't need to say anything. It can cause intramuscular hemorrhage. Now we come to the subcutaneous route. So it's a simple diffusion process. It also, exists in two formulations. One is the aqueous and the other is the depot. Aqueous is rapid onset of action and depot is slow and sustained release. That means the duration of action will be large. Coming to the merits, it is suitable for slow releasing drugs. It is good for poorly soluble suspensions. And there is a low risk of hemolysis or thrombosis, which is common with IV. So in IV, most of the medications you have seen the side effect as thrombophlebitis, etc., etc. Those kind of issues usually are not seen with subcutaneous route. If you look at the demerits, if the drug is irritating or used with any kind of irritant forming drugs, it can lead to severe pain and necrosis. This is not applicable for drugs with large volumes. Obviously, you cannot give a large volume through the subcutaneous. So there are some examples like epinephrine, insulin, and heparin. This is not very common. This is the intradermal route. So in this condition, the drug is actually injected into the dermis. Please don't confuse intradermal with transdermal. Intra, you should understand the meaning. Intra means inside, trans means on the surface. So please don't confuse between intradermal and transdermal. So dermis is the most vascular layer of skin, present just under the epidermis. So that is where we usually inject. It does not have any significant disadvantage because we don't use it over a wide application. So it is usually used for diagnostic purposes or desensitization purposes. Now we come to the rectal route. So the problem with rectal route is the absorption is very incomplete and erratic. So that is a problem with this rectal route of administration. You can't predict the rate of absorption. The merit is it partially escapes the first pass effect, approximately by 50%. Definitely stomach acid destruction is avoided because it is anyways not going into the stomach because you inserted it through the rectum. This is also good for emetogenic drugs. Like for example, there are certain drugs which cause severe nausea or emesis. Or if the patient is already having a tendency to vomit, if you give it through the rectal route, the chances will be very less. And also to some extent, it is good for patients who are vomiting or comatose. Demerits, there is a risk of mucosal irritation. Anyways, it is inserted through the rectal route, so there is a risk of mucosal irritation. Acceptance issue is a big thing because definitely the route of administration is not that favorable. So there may be some patients who might not be able to come to terms with administering a drug through the rectal route. So that is a problem. There are certain examples, for example, bisacodyl, promethazine, and diazepam. Diazepam is usually used in pediatrics. Rectal diazepam is available. Promethazine is actually a very powerful antihistaminic and also an antidopaminergic agent. So that's about the rectal route. Now we come to the last topic, that is the other routes. Oral inhalation and nasal preparations. So they provide rapid delivery of drug across a large surface area of mucous membrane of the respiratory tract and pulmonary epithelium. Because the respiratory tract and the pulmonary epithelium, they usually contain a large surface area. The drug is delivered rapidly, so you can expect a good onset of action. But it also depends whether it's a short-acting medication or a long-acting medication. The drug effects can be comparable to IV bolus to some extent. There are certain gaseous drugs, for example, anesthetics, and those which are given via aerosol. So they can be given via inhalation. Through inhalation route, the drug is delivered directly to the site of action. So site of action means it will be in the lungs only, the respiratory pathway. So the risk of systemic side effects will be less. Means it will not enter into the systemic circulation very easily. So this is actually good for patients with asthma and COPD. That's why we use inhalers or whatever it is in asthma and COPD. The intranasal route, it provides topical delivery of the drug inside the nose. So that is good for patients who are suffering from allergic rhinitis. If you look at the merits, rapid absorption, that's very good. It is good for gaseous medications. It is good for respiratory problems, as I said, inhalation route. Dose titration, to an extent, it may be possible. Lower dose is required to target the lungs. For example, you're suffering from asthma or COPD. If you give a particular bronchodilator or something through the systemic route or the oral route, the dose will be high. But if you are giving through an inhalation formulation, the dose required will be less. So that is a very big advantage. So obviously, since it is not very easy to go into the systemic circulation, the risk of systemic side effects will be. Obviously, it depends on whether you are overdosing on the inhalation or something like that. That is another thing. But in normal scenarios, systemic side effects are not that common. If you look at the demerits, the drug enters the brain very quickly. So there is a high risk of addiction. This is difficult for patient to regulate the dose. So usually what happens, dose titration by the patient is not possible. And patient difficulty in using inhalers. So this is also another thing. You have to give a load of counseling tips to a patient who is taking inhalation, inhalers. Especially if it is a steroid inhaler, you have to advise them to wash the mouth properly and also wash the mouthpiece properly. And to gargle with maybe lukewarm water or something like that if they are experiencing any kind of throat pain or something. Because steroids, they usually increase the risk of oral candidiasis. So this is just an example. There are a lot of counseling tips that we need to give to a patient when they are using inhalers. So it is not always necessary that patient may remember all these steps one by one when they use an inhalation formulation. So the risk of medication non-adherence may also be high. Now we come to intrathecal or intraventricular. You can see two images here. Intrathecal is a targeted delivery of the drug directly into the spinal fluid. And intraventricular, as you can see, it is directly into the brain. The problem is that why we focus on this is because blood-brain barrier actually prevents or delays the entry of some drugs into the CNS. So if you need local rapid effects, then the medication should be inserted or introduced directly into the CSF. So that is how we get the mechanism of action. So for example, teicoplanin, amikacin, amphotericin B. There are a lot of other examples also which can be given through this routes. Then we come to the topical route. So topical route, it is usually desired for local effects. So, but again, the absorption depends on two conditions. What is the condition of your skin and what is the condition of the area near to the skin? So which area of the skin are you targeting and what is the area of the skin in that particular location? So if you look at the merits, if you want local effects, then it is a good option. Obviously, if you want a topical cream or maybe eye drops, intravaginal or intranasal products, then definitely topical route is a good idea. There is a very low risk of systemic absorption. We can't say that there is no risk at all. There is a low risk. And patient convenience is also very high. So it is not a very big matter of concern. Coming to the demerits, there is a slight risk of systemic absorption. Depends on what kind of topical formulation you are using and in what dose. So that can be a matter of concern. So for example, there are some medications like isotretinoin and something like that. So Lot of formulations are there. I mean, lot of medications are there in the topical route, which we have to be very careful because of the risk of systemic problems. This is actually not a good option for those kind of drugs which are having high molecular weight and low lipophilicity, because lipophilicity is a compulsory thing. So higher the lipophilicity, better the absorption of the topical route or through the topical route will. We have some examples like clotrimazole cream, which is an antifungal, hydrocortisone cream, and definitely timolol eye drops, which are used in glaucoma. Coming to the last part, that is the transdermal route. So this drug is given via a patch on the skin. That's why I said don't confuse between intradermal and transdermal. Transdermal means on the surface of the skin. So systemic effects are achieved. Examples, nitroglycerin, nicotine patches are available, you know that very well, and scopolamine. Scopolamine is an anticholinergic. The rate of absorption depends on the physical features of the drug at the application site and definitely the lipophilicity of the drug. Coming to the merits, the first pass effect is bypassed, which is a very good point. It is convenient and painless. Transdermal patches are usually not painful. It is good for highly lipophilic drugs. It is good for drugs in which the oral bioavailability is very low. So if a drug is having very poor oral bioavailability, then you can give it through the transdermal. It is also good for drugs which are quickly eliminated from the body. So the risk of toxicity will be low. Coming to the demerits, there are always risks of patch allergy. So it depends on how the skin receives that particular patch. So there are risks of patch allergy. So it can cause irritation, itching, redness in that area. This is only applicable for those drugs with high lipophilicity. If the lipophilicity is low, then it is not a good choice. Delayed drug delivery. So if you want rapid action, then this might not be a very good option or very good choice. And obviously, it is only good for those drugs that can be given in small daily doses, not in huge doses. So that's it with this presentation on route of drug administration. So I hope I have been of service to you. If you need this presentation or my notes, you can contact me in LinkedIn. I will be there to be of service. And if you need any kind of career guidance, or if you are struggling with your studies, practical knowledge, anything related to that, please contact me at LinkedIn. Please message me there. My name is Vishnu R. Nair. You'll definitely find me. That's it. Thank you so much for listening to me. I'll be back with another video which can help your competitive exams or BBC exam or practical knowledge perspective. Until then, it is goodbye.